My name is Carrie Hill. I'm a gastroenterologist here at the Billings Clinic. Do lots of colonoscopies every single day. So, again, the anatomy. There's the colon starts in the right lower quadrant of the abdomen where the cecum is, and that's the beginning of it. And it goes up and across and down, and it kind of squiggles through the sigmoid colon and down to the rectum. And so during colonoscopy, we look at all of these areas and look for precancerous polyps there. So colon cancer is the second most common cancer in females and the third most common cancer in males nationwide. There's about 150,000 new cases in the United States annually, and about 50,000 people die from colon cancer on an annual basis in the United States too. And this accounts for about 9% of all the cancer deaths that occur in the United States. So it's a big deal. In Montana, it's the fourth most common cancer behind prostate, breast, and lung. And here in Montana, we have about 180 people that die from colon cancer on an annual basis. The incidence of colon cancer is the highest in North America, Europe, and Australia for reasons that I'll talk about, we think we know, that I'll talk about in a little bit. In Africa and Southeast Asia, they have very little colon cancer. Most colon cancers are not associated with family genetics, although we worry about people that have family histories. Age really is associated with colon cancer, and as people get older, their risk of colon cancer goes up year after year. And the precancerous polyps and the actual cancers that we find are more common as people get older. So overall, though, the rates of colon cancer seem to be declining about 2 to 3% per year. We'd like to think that colonoscopy is the reason for that. A person's lifetime risk of getting colon cancer is about 5%, and again, about 90% of it occurs after two people turn 50, which is why, in general, 50 is the age we start screening for colon cancer. It's more common in men. It's more common in African Americans. And then we've also noticed a trend that there's an increased incidence in colon cancers that occur in the ascending colon, which is the upper part of the colon that's not reachable by the short scope or sigmoidoscopy, which is, I'll talk about that in a little bit, which is then resulted in the increased importance in having a full colonoscopy as a screening device rather than just a short scope. The death rate of colon cancer is also declining in the United States. Again, we like to think it's because of colonoscopy and people being more aggressive in screening for that. We are doing lots of colonoscopies. We're removing the precancerous growths before they can do anything. We're catching cancers early when they do happen, and that improves the outcome, as Dr. Murray talked about a minute ago. In general, the treatment modalities are also getting better. Chemotherapy is getting better. In the United States, we have one of the highest survival rates of colon cancer in the world. And again, like Dr. Murray said, about 60% of all comers end up surviving after 5 years, which is pretty good. The rest of the world, they're not doing as good a job, and the mortality rates are actually climbing throughout the rest of the world while they're declining here in the United States. So there's a few risk factors. Obesity, possibly. Like I said, males and African Americans seem to have a higher incidence of colon cancer. I will say that women, though, once they hit menopause, their incidence of colon cancer starts going up at that point. And so there is some protective element from the hormones, but beyond that, no one's really sure what that means. Smoking and red meat possibly also are risk factors as well, although there's conflicting studies and it's not very clear. Being physically active, eating a high fiber diet that's rich in all things that are good for you seems to be protective against colon cancer, as with lots of other cancers. And a lot of these things have been studied individually, and there's really no clear one thing that helps. But being active, not being obese, eating a good diet seems to help for lots of things, including colon cancer. Clearly, drugs like aspirin and ibuprofen and the other drugs of that class clearly decrease the risk of colon cancer. It's not enough that we recommend that people take aspirin as a preventative measure. There's a lot of people that get complications from aspirin and these other drugs. But if someone's already taken them because of their heart, then this is a good thing too. It's good for other things than just your heart. Unfortunately, most people that have colon cancer don't have any symptoms, and they come in, they get we pick them up on screening. Or they go in and have routine blood tests, and they're found to be anemic. That's a really common way for us to pick up people that have colon cancer too. Other things, sometimes people get abdominal pain, sometimes they see blood in their stool, and often they're very fatigued, and again, that's mostly related to the anemia. So there are family histories that put people at very high risk for getting colon cancer. There are 2 cancer genetic syndromes that have been identified that cause about 5% of all cancers, and then there's other people that have family histories that put them at higher risk too. So familial adenomatous polyposis, or FAP, is a rare, but we find it. There's a few families in Montana. There's at least 3 or 4 that I've had in my practice here in Billings that have this. They have thousands of polyps in their colon, and they start getting symptomatic in their teens. They get anemic. Almost all of them have colon cancer by the time they're 45, and they're also at risk for other cancers in other parts of their body. So this is a picture of someone with FAP. So all those bumps are colon polyps. So you can imagine we can't possibly take all of those out during colonoscopy, and so these people in general just go and have a total colectomy and have their colon just taken out. Lynch syndrome, or HNPCC, is hereditary non-polyposis colon cancer syndrome. We actually have a number of patients with this in Montana. We pick this up on a fairly regular basis. And when we have people that have a young colon cancer, we send all of their tumors out to be tested for this because we pick it up so much, and then they get genetic counseling, and their families all need to be screened. They mostly get colon cancer in their mid-40s. Sometimes it's as low as their 20s, though. Usually they're hard to find cancers. They're up high. They don't cause any symptoms. And again, these are a lot of people that we pick up just by being anemic. And again, there's a number of non-colon cancers that also can happen with this. And so once we identify that someone has this genetic mutation, they get all kinds of screening for all kinds of other cancers like endometrial and pancreatic and that kind of thing. So people that have a family history of colon cancer are also at increased risk. They have about a 2 to 8-fold risk compared to the general population. We defined this as a single first-degree relative who has colon cancer who's under the age of 60. So first-degree relative is really just parents and siblings. As people get older, too, their children sometimes get picked up as having colon cancer, and then we'll have the parent come in and we'll pick up polyps and colon cancers that way, too. It also counts if you have 2 first-degree relatives that got colon cancer at any age. Again, the single first-degree relative needs to be under the age of 60. But then if you have 2 of any age, then that puts you at increased risk. And then also if you have a first-degree relative that has a big polyp or a polyp that had advanced changes that were getting close to cancer, that also makes their siblings and parents at increased risk, too. If once we identify a person that grows colon polyps, though, they are also at increased risk of developing colon cancer in the future because we know we grow them, and so we need to keep a closer eye on those people so that they don't grow new ones that can get big and change. When someone has a colonoscopy, we take off a polyp, there's different kinds of polyps, and some of them are non-precancerous, and those don't count. We don't really care about those. So your own personal risk depends on the pathology of the kind of polyps you had, the number of polyps you had, and how big they were. And that helps us gauge how closely we need to follow people. The other people that have an increased risk of colon cancer compared to the general population are people with ulcerative colitis or Crohn's disease, which are collectively called inflammatory bowel disease. And they have up to a 15 times risk of getting colon cancer. And after about 8 to 10 years of disease, when people have this, we start doing annual colonoscopies because the colon cancer risk is so high in that population. So screening is important. I do it every day. I feel like I change the course of people's lives, and I think it's really important. The most common reasons that people don't get screened is because they didn't think about it, the doctor didn't tell them about it. A lot of times it can be too expensive, and fear. People often fear it. It's kind of an embarrassing kind of thing. So we've actively tried to overcome these. And the primary care department has been really good at really getting it on people's radar. So there's a number of ways to screen for colon cancer. There is a stool test that can be done on the stool. It looks for microscopic traces of blood in the stool. That's what we use here at the Billings Clinic, is the one that tests for blood. There is a new stool test that looks for DNA, colon cancer DNA, that can be in the stool. And it's really good at detecting colon cancer, but it's terrible at detecting colon polyps. And so in general, we don't use that as a screening test. The blood test, the stool test looking for microscopic traces of blood is extremely cheap, but it's also really unreliable. And we get lots of false positives, lots of false negatives, and in general, anybody that has a positive test gets a colonoscopy. If it's going to be someone's main screening tool, it's recommended that it be done annually. If they go on to have a colonoscopy, we recommend that they not have a stool test for about 5 years, because then if it's positive, then we're compelled to do another colonoscopy. And so once you've got the colonoscopy, you're good for at least 5 years before you start looking again. Barium enema is an old test. It's an X-ray study where they infuse an enema of barium, and then they take pictures, basically. It's notoriously inaccurate. It misses up to 50% of even big polyps. And so in general, it's not used anymore as general screening. And then if there's anything on it, obviously, then you have to go to colonoscopy. CT colography is something fairly new. It came out about 5 years ago. It is a CAT scan where you have the CAT scan done, and then the computer does these reconfigurations and makes it like a colonoscopy. So it requires a full prep of the colon. It's the same prep that we use for colonoscopy. It's much better than barium enema, but it's not as good as colonoscopy. It misses flat things because it's looking for filling defects into the colon, and a lot of those right-sided polyps are very flat, and they're hard enough to find in colonoscopy. They're nearly impossible to find with this. Any positive finding on the CT colography requires a colonoscopy. In general, they don't sedate for this, and so it's actually apparently very uncomfortable. They infuse an enema of air, and then they inflate the colon, and then you hold it and then go through the scanner. And in general, people find that very uncomfortable. And then there's the radiation exposure that can happen. And so when the government looked at this, the U.S. Preventative Services Task Force did not recommend this as a screening tool, and therefore Medicare won't pay for it. It is available here in Billings. I know that St. Vincent's Hospital, I have some patients that want to do this instead. And that, it's okay. Again, it's it misses somewhat. It can miss flat, important colons in the right colon, and we hate that. Flexible sigmoidoscopy is a short scope. It looks at the rectum and sigmoid colon, which is about the distal 30% of it. It also does not require sedation. It's kind of a quick in and out. Although if they find anything, you got to do the prep and come back and have a full colonoscopy. It is one of the recommended screening tools, though, and so in general, the recommendation is to do the stool fecal occult blood test. So the stool blood test every year, combined with this every 5 years, is one of the recommended colon cancer screening modalities. This one, again, in the past, the most important polyps seem to happen in the distal part of the colon. These days, it's not like that anymore. I tell my patients that we don't do mammography on a third of the breast, and so in general, it doesn't make a lot of sense to only look at a third of the colon. So this has largely fallen out of favor for primary screening. So colonoscopy, it has the highest sensitivity, so it picks up the most polyps and does the best job. We take the polyps out right then. It does require a full bowel prep, so you have to drink some stuff and get your colon clean before we can do it, and that we have some options, but in general, the end result's the same, and it's not a super fun night the night before the procedure. We sedate for it. There is a risk of perforation and bleeding. The risk of those is somewhere between 1 in 500 and 1 in 2,000. As people get older, the risk gets higher. So in the Medicare population, it's about 1 in 500. In the general population, it's about 1 in 2,000. The sensitivity of the exam, or how many polyps get picked up and found, depends on who's doing it. There have been studies that have shown that the more you do, the better you are at it, and you pick up more stuff. And so a family practitioner who's doing colonoscopies probably doesn't pick up as much as a general surgeon who's doing colonoscopies, none of which pick up as much as a gastroenterologist that's doing colonoscopies. And so I think it's reasonable to ask whoever's going to do your colonoscopy how many they do, what their polyp detection rate is, how long they've been doing it. I think those are all fair questions. And the more people do, the better they are at it. So for the general population, average risk person, we recommend that you start at age 50 and stop at age 75. Now, not all 75-year-olds are the same. I tell my patients, some 75-year-olds are very offended when I suggest that they no longer need to have screening colonoscopies. I mostly tell them that I'll be here, and if you want to come back in your 80s, I'll do it if you want. But in general, the recommendation is age 75 to stop. The cost effectiveness of all the options appear to be similar. Any of the other ones seem result in a colonoscopy if they're positive. And so in general, it seems most cost effective to just jump to a colonoscopy and then you're good for 10 years and you don't mess with the other stuff. However, and then we do colonoscopy routinely every 10 years, unless you have a polyp or you have a family history, and then we do it sooner every 1 to 5 years, depending on what we find. So these are the screening options that are recommended by the cancer people, is that every 1 to 3 year stool test plus a flexible sigmoidoscopy or the short scope every 5 years, a CT colography every 5 years, that's the virtual colonoscopy, or a colonoscopy every 10 years. In general, CT colography costs around here in Billings, they're charging about $1,500. A colonoscopy costs about $2,500, unless there's pathology fees, and that makes it different. So if you're doing a CT colography every 5 years versus a colonoscopy every 10, colonoscopy is actually even more cost effective. So people, though, that are high risk, we really strongly recommend that they really only use colonoscopy for their screening modalities. And we typically, in a family who's got colon cancer in a relative who's under the age of 60, we recommend that you have your first colonoscopy at age 40, and then, or at 10 years younger than the youngest cancer. So if someone in the family got colon cancer at age 48, then we'd recommend starting at 38. If negative, if the colonoscopy is done and it's negative, we still recommend you come back every 5 years because, again, there is some genetic component to this, and we feel like we need to keep a closer eye on the people who are at genetic risk for making polyps. If you fall into the high-risk category based on one relative who's younger than 60 and your first colonoscopy is negative, the current recommendations are that you can go to the average every 10-year club. We're a little worried about that. I'm not completely ready. This is the new recommendation that came out last year. We haven't totally embraced it yet, and I kind of talked to people about but in general, I still favor every 5 years, just because we hate to have somebody come back at 10 and have cancer at that point. So like I said, if you've had your own colon polyps, then depending on the pathology, so how nasty the polyps were, how many you had, how big they are, then we bring you back every 1 to 5 years, kind of depending on the opinion of the person who found them.
Hi, I'm Brett Murray. I'm one of the general surgeons here. My area of interest is in colon and rectal surgery. I also do metabolic surgery too. And there's another particular area of colon and rectal surgery that I think right now I'm the only one in the state doing, so it's worth talking about because not many people are aware of it. But we'll go a little out of order. I think this slide kind of points out the important thing about early detection. The smaller a polyp is, the less likely it is to have malignancy in it. So under a pea-sized thing is only a little more than 1% chance of having actual malignancy in it. But just double that makes it at least half or 50% probability, pretty close, of having cancer. So better to find them early and get them out. Once you do actually have the diagnosis of cancer based on a biopsy that most likely Dr. Hill would be doing with her colonoscopy, you have to do staging so you know the appropriate way to treat the actual cancer. And this slide kind of points out the basics about how, or the concept anyway, of a smaller would be a stage 1, and that pertains to how big it is, how thick it is relative to the structural wall of the colon or rectum, and then whether there's any evidence. This only goes to stage 3. There is a stage 4, but that would be indicative of actually metastatic disease elsewhere in the body, not just in the area. So the basic system that everybody relies on nowadays is the TNM system, and that refers to the T is for tumor size relative to the wall of the colon or rectum, and then the number of lymph nodes is what N refers to, and M being again the metastatic disease if there's evidence of any tumor spread to the lung or liver or elsewhere. So T1, this is kind of getting in the weeds a little bit. T1 is obviously a better one to have. It's an earlier stage, and it just is going through the innermost layer of the colon wall into the second lining. And then 2 would be into the muscular layer of the tube that the colon is, which it's a kind of a muscular tube. T3 would be all the way through the muscle and into the fat that surrounds or encases the colon or rectum. And T4 would be invasion, either freely perforating into the abdominal cavity or invading into surrounding tissues. So lymph nodes, that's the other important designation for most people, because that's typically part of the stage that the Western society patients end up with. 1 to 3 lymph nodes of the entire amount sampled, if those have tumor in them, then that would be N1, and then anything 4 or more would be N2. There's no such thing as N3. So again, this is all about timeliness. If you catch it early, you're in better shape. But right now, I think these are the current numbers, a little bit more than 1/3 of people in the Western world have disease that's just confined to the wall of the colon or rectum. And then a little bit more than 1/3 have lymph node involvement as well. And 1/5 of people actually have metastatic disease elsewhere when it's found. Now, keep in mind, these numbers are as it is now, not with people being 100% compliant with having their first screening colonoscopy at age 50, because we don't follow rules well. So, again, earlier is better. If you catch it while it's just confined to the colon wall, your chance of being alive and well at 5 years is over 90%. And that drops to about 2/3 if the lymph nodes are involved, and way, way down to 8.5% if you have metastatic disease right off from the diagnosis. So part of the whole process is staging, like we said, and before we do anything, a lot of that involves imaging. CAT scanning is pretty much a staple. We do most of that work with the CAT scanner. But other specific parts of the colon and rectum, you need to do other things. We'll talk about that a little bit more here in a second. Surgery is actually not only treatment for colon cancer, but part of the staging too, because we don't have an accurate or definitive stage until the tissue is on the bench with the pathologist being looked at under the microscope. And the pre-op staging, doing our scans and all that stuff is important because it might determine what order or how much therapy you get, meaning particularly in the case of rectal cancer, if it's an advanced tumor early on, then you get chemotherapy and radiation, at least recommended before doing any surgery. So we talked about the scans. The CEA thing is another thing worth mentioning. That's a blood test that we do just to kind of have a baseline to follow over time afterwards. Let's see, I got a picture here of an endorectal ultrasound that this is an example of somebody that has rectal cancer that clearly should have chemotherapy and radiation first. This is a a conglomeration of computer pictures that's gathered by the ultrasound probe that we use by bouncing sound waves. And you can see how irregular this surface is here. This should be a continuous bright line right here, and you can see that it's pretty roughed up and irregular. And then as I'm moving through the three-dimensional cube here, you can see there are little dark spots like this one. That's a lymph node that has tumor in it. That's a lymph node that has tumor in it. So that's a good example of somebody that let the horse get out of the barn. So this is just a little anatomy lesson about the parts of the colon and how we deal with it when we have the diagnosis. And it pertains mostly to the blood supply that goes to each of these segments as far as what part you take out based on where the tumor is. So you want to, if you have the diagnosis of actual invasive cancer, not pre-cancer or anything like that, then you're most commonly going to want to remove the whole segment of the colon, again, including the suspensory tissue, the blood vessels, and the lymphatics that go to that segment. So these are the names of the operations that we do. You can do most of these open in the traditional way or laparoscopically with the little incisions and inflation of the abdominal cavity with carbon dioxide using a magnified camera, with the benefit being less pain, earlier recovery, get out of the hospital sooner, back to work sooner too for a lot of people. The lower ones here, I think I talked about that a little later here. The low anterior resection, abdominal peritoneal resection, those are operations that are mostly done open just because of where they are in the body, and they're not really reachable with a scope other than with the robotic assisted laparoscopic surgery, and that's still pretty much cutting edge stuff that we don't do much of yet. And then the last part, the transanal excision, that's something that we can do in the case of an early stage, and I'll go into an example of that. So that's a picture of somebody doing laparoscopic surgery, not me, because I don't hold with having cameras around, but it looks pretty civilized, I think, better than kind of the open, messy stuff. And here's a good example of how incisional scars might look after healing up from a laparoscopic surgery. That would be the ascending or right colectomy there. It's fairly imperceptible, actually. You kind of see that's the main incision where things get removed through. And that's a good example of what it looks like. You free it up completely from the inside and then kind of feather it out through the little incision. Also, you can see on this picture an important thing. That's a tattoo that Dr. Hill or one of her colleagues might have placed for us to be able to know that we're aiming in the right direction to remove the tumor, because they're not always perceptible either by vision or by feeling. There's another example of a tattoo, not as glamorous as a Harley rig or anything like that, but more examples of how incisions might look after a laparoscopic surgery. And then we talked a little bit about the robot. I think that's still kind of emerging, but it's something that's going to be more and more common, I think. As far as the rectal surgery goes, whether it's done open or laparoscopically or with a robot, there's still functional concerns because the rectum isn't just a simple tube the way sort of the rest of the colon is. It has to coordinate with your sphincter muscles, and there's actual complexity going on, and it's surrounded by some important nerves in the pelvis, particularly for erectile dysfunction and bladder function. So it's an operation that we can do and do well, but if you can avoid it, all the better. The abdominal peritoneal resection, I think, follows in that category as well. Obviously, for most people, they wouldn't want to have a permanent colostomy if they didn't need to, but this is the operation that you do for a cancer that's so low and right on top of where the sphincter muscles are that you can't remove the cancer without removing the sphincter muscles as well. So it's a good example of another thing to avoid by early detection. Now, some tumors, if they're early enough, or if the patient in question is unable to tolerate a major operation, you might be able to at least remove it and give local therapy by removing the tumor transanally, literally. I don't know if I have a good cartoon in here of how that's done, but This is the procedure that I was talking about earlier, the transanal minimally invasive surgery. And right here is the port that actually connects to this. This is the actual plastic device that goes through the anal canal and allows us to do the procedure. This is an example of a TAMIS procedure where the rectum is filled with carbon dioxide gas, much like when Dr. Hill does colonoscopies, things will be filled so they have a good camera view. And the camera is magnified so we see better than just the naked eye. And you can, if I get my mouse working here, there. That's the early stage tumor right there. It's not big and not particularly heaped up, but it is biopsy-proven cancer. So what we do then is mark out the edges of what we want to take with the cautery. You can see the little scorch marks. And then we use other equipment that's more effective at dividing and sealing blood vessels to take it all out in one piece. And that's a key concept, one piece. That's what it looks like after it's stitched closed. And then in one piece we can give it to the pathologist and give them directions about which part of the specimen points in which direction. And so here's an example of how something might be taken out the old style with little chunks at a time using a colonoscope. This is the type of specimen that you can get from the transanal approach. So then after you've finished surgery, then you have to think about whether there's chemotherapy in your picture, and that's usually recommended for people that have a T stage of 3 or more, or if there's any evidence of any lymph node involvement. And for most regimens, it lasts about 6 months. It's like having a part-time job for most people, but it varies a lot what the side effects are like. The benefit being that you get statistically a 10 to 15% increase in your chance of survival at 5 years. And the 5-FU, leucovorin, oxaliplatin, those are just some of the names of the chemotherapies that are most common. So that's kind of the fine print, and that's a small fraction of it that you can have to consider for any of the treatments, including surgery and the chemotherapy afterwards. So again, a good advertisement for catching it early and avoiding the treatment if you can. Follow-up, after somebody's had colon cancer, we have to suspect that it could recur, and when they do happen, it's usually within a couple of years. So we watch you like a hawk with exams, lab tests, and CAT scans initially. And then the farther you get away from the treatment, the less likely the recurrence is, and so we can avoid doing unnecessary tests. Colonoscopy, again, is key to keep an eye on things. So those are the people that I stole pictures from. Thanks.